Good morning, everybody. Maybe we turn down the volume in the room to avoid the echo. Is that okay? Turn down the volume up there so it doesn't come through these speakers.
It's like echoing.
Turn it down. Okay. So then we get less of an echo. That's all. Good morning, everybody. We're here at the empty lecture hall, and I'm here to introduce Dr. Sarescu, one of our heart failure specialists who has run the heart failure team and patient care at Midtown for many, many years. He is going to dovetail onto what you learned from Dr. Gupta on Monday and talk about the clinical presentation and management of heart failure and try to bring a lot of these difficult concepts together, approaching some from a different angle to help you understand them. And I'll turn it over to you, Dr. Sarescu. As with in the past, if you have questions, please chat them, and I'll raise my hand and speak for you, and he'll answer the question. And he said he welcomes the interruptions to answer questions.
Thank you, Dimitri. Oh, yeah, maybe we need to. I don't know. You know better.
I think so.
Can you hear me? Dimitri, can you hear me? Yeah.
Absolutely.
Okay, all right, very good.
I don't think it matters.
Okay.
How it transmits, does it?
So what happened to the screen? I don't know. I'm glad you're here. Maybe from here?
Yeah.
Maybe we just need to exit and re-enter from PowerPoint.
We switch sources here.
Oh.
There we go.
Okay, great. Okay, a little glitch in the matrix. Good morning, everyone. I have really no conflict of interest to report. A little bit about me. I've studied medical school in Romania. I came here as for training in residency in internal medicine at Beth Israel, where I received a very robust clinical training about 25 years ago. And then I moved at Emory for cardiology fellowship with a very clear intention of really learning the scientific basis of heart failure and cardiology. And I had a special interest of this for over 25 years. Really for about 15 years, actually, I spent time in the lab doing basic science research. I actually succeeded at one point to have my own lab for about 10 years. About 5 years ago, I decided due to just heavy work to focus on clinical education of both patients, future doctors, cardiology fellows, and really my passion is actually dealing with patients with chronic heart failure, which is often not a condition that involves just the heart, but also multiple comorbid illnesses. For those who are interested and they want to follow up on some concepts I'm going to put here together, they can actually go to, I created a portfolio of heart failure lectures on YouTube these are my regular grand rounds on different topics of heart failure that are given for students and residents and fellows. And you can expand that on that YouTube website. So this presentation is going to be a little different from the one that Dr. Gupta has given to you. You have watched lectures. They're more of a textbook style. You have reviewed basic concepts of heart failure and pathophysiology and pharmacology. However, this is about trying to put those concepts together in a clinical scenario, which is a little different. These concepts are not in the textbooks. Basically, it's more of how we use the concepts when you actually see a patient, either with acute heart failure that presents to you or with chronic heart failure, both in understanding their clinical presentations, pathophysiology, but also the therapeutic options we have for these patients. So we're going to talk about how is it different, how is an acute heart failure patient will present versus a patient with chronic systolic heart failure. And notice I put here systolic. That means this is a patient with weak heart that's been has lost its ejection fraction, but a lot of these concepts we'll see apply the same for diastolic heart failure. The second part will be talking not so much about clinical presentation, but really about pathophysiology and especially treatment in acute versus chronic heart failure. And you'll see there are some similarities, but there are some differences. So, you know, the best way is to just present a simple patient. This is a patient that actually is my patient from Heart Failure Clinic, who originally a couple of years ago presented suddenly. She's about 68, and she presented for 2 days worth of dyspnea and exertion, and which is now at rest. Basically, it's at rest. That's class 4 New York Heart Association. She is having some fatigue, anxiety, nausea, and dizziness. She went to her primary care physicians for these symptoms, and then primary care physician noticed her heart rate was about 160 and sent her to the emergency room. After she was admitted in the emergency room, and after we talked to her, turns out she's been having actually quite a bit of shortness of breath, not just for a couple of days, but gradually progressive over the past month. She really only noticed in the last 2 days. She was distracted with her work. It's gotten to the point she just learned to automatically kind of limit her exercise. When I ask her, well, how was it? What could you do a month ago versus what can you do now? And I say, you know, if I think about it, about a month ago, I kind of stopped, you know, going out. I stopped shopping. I mostly work in my studio. She's a Hollywood producer, and I just do my work and then I go home. I'm wiped out. I can't really do anything else. So even if this is a subjective question in patients who've been having these symptoms more subtle for a while, you can actually compare their own activity prior with now. You can make it very objective. Now, of course, in the last few days, what was really the dramatic part is the orthopnea. I mean, she had to sit up to sleep. Paroxysmal nocturnal dyspnea. You know, she was feeling like she was drowning. She was having some dry cough each time to try to sleep on her back, and she couldn't sleep. You know, period. And but also, and these are symptoms of congestion of the lung. But you can have also congestion in the gut, in the abdomen, and mostly liver or in the gut, and you know, may manifest initially with just eating smaller and smaller portions and feeling full before you basically you can't finish the whole plate. You eat first a third, and then eventually maybe an hour later you eat the rest third. But in more advanced stages, you can actually stop eating, nausea, vomiting, start to drop meals. Usually the last meal to drop is the one after prolonged fasting, like the breakfast will be the ones preserved the most, while the lunch will be probably first to go. And in more advanced stages, you can actually, after you fill the lungs with fluid, you fill the abdomen with fluid, eventually you can see fluid in the legs too. But by the time the fluid accumulates in the legs that we can notice it, usually there are at least 5 to 10 pounds of central fluid overload, what we say as opposed to peripheral, that will show in the legs. Now, on a physical exam, this particular patient had a blood pressure was kind of borderline. It wasn't, it was on the low side, but still on the normal side. At a very fast heart rate of 160. She was really breathing fast, tachypnea, that's called. Normal should be 16 to 18 if you're at rest. And she was her oxygen level was a little bit on the normal towards hypoxia side. She had clear evidence of congestion with jugular venous pressure that was elevated. On the lung exam, she had rales on both sides, particularly the bases, and the dullness and the reduced breath sounds of the left lung base suggested a left pleural effusion. On the heart exam, she had the irregular heartbeats suggesting of basically atrial fibrillation. There was no murmur, no pericardial rub, and she did have some 2+ peripheral edema. So what we basically is a patient who presented with congestion. And when you look at this patient, the first question you need to ask, am I dealing with an acute heart failure? Am I dealing with chronic heart failure, or this is acute on chronic heart failure? Even for this patient will be the first presentation. And acute in general, is a loose term, something that just happens suddenly, maybe for hours, maybe at most days. Chronic is something that's been going on for weeks, months, or years, and it may not necessarily be detected until now. And this particular patient, and actually after we talked to her, she did have clear and acute presentation with signs of congestive heart failure. However, after we talked to her, she's been having more subtle symptoms of chronic heart failure for at least a month or two. When you try to talk to the patient, really try to classify basically when it comes to heart failure in two kinds of symptoms. The congestive symptoms, which is extremely important usually for the patient, that's actually what brings them to the hospital. That makes the acute part of it. And then you have more chronic symptoms of what we call a low perfusion or low cardiac output, where they actually have fatigue, tiredness, they can think straight too well, basically in advanced stages, they will not be able, they will notice a urine output is going to decrease. In early stages, actually, urinary output is increased, but usually at night when the kidney can relax. It's called nocturia. But in more advanced stages, actually, overall, they notice, well, I can't seem to be able to urinate and have very little urine output. So again, make it easy, classify your signs and symptoms in congestive symptoms, a fluid overload, that's important in the patient. You can have more, and I usually like to actually do a central kind of congestion versus peripheral. The peripheral is the one in the legs that everybody can see. The central is usually what the patients feel, and which will be more difficult to elicit on the physical exam. For example, we can see a jugular venous pressure is elevated. That would be evidence of a central congestion. But if you talk to the patient, if they have orthopnea, they have proximal nocturnal dyspnea, if they suddenly say, I have stopped going out of the house, as opposed to a month ago, I could go shop at Walmart, that's a sign of, and why? Because I'm short of breath, then that's a sign of, more solid sign of congestion. Or sometimes they will tell you they're not able, each time they have to tighten their shoe, they're gonna, and lean forward, they're gonna feel short of breath. That's a sign of congestion too. So there are some more subtle and some more obvious signs. And this particular patient, obvious, has more of a acute on chronic progression of the heart failure. And I borrowed this slide from Dr. Gupta that reflects that actually probably the patients that I see, most of them have more of a chronic progression with some moments of acute, component on top of that. So if I were to now separate my acute from chronic heart failure, and remember most often than not, you can have acute on chronic, then the acute heart failure is gonna be clinical noisy, all right? You're gonna have rapid development. There are no compensatory mechanisms. So patient basically suddenly will be flooded with fluid in the lung, will be extremely short of breath, will breathe fast, the oxygen may drop. Same way will be on the right side. If you have congestion in the liver or the stomach, you're gonna have pain in your upper quadrant where you have the liver, you can have early satiety. There are clear, obvious signs. You have if you listen to the patient's physical exam, you're gonna have you can have a dilated heart with a positive third sound, a displaced point of max intensity. In other words, this suggests the heart not only is dilated, but also it's weak. It's a low ejection fraction. The S3 usually comes, the third sound is positive with a patient who has dilated cardiomyopathy, a low ejection fraction less than 30%, but it's also volume overloaded. It's a sinus volume overload because it really comes at that interface between early and the rapid and mid feeling. Basically a first third with the second third of diastole, early in diastole, when you switch from a rapid to a slow feeling, and it hits a very prior left ventricle that's enlarged and already elevated LVDP. You can hear murmurs, which you can get functional mitral regurgitation from a dilated heart. You can have rales most of the time. In anybody with acute heart failure, they will have about 85–90% of them will have rales. And the usual elevated jugular venous pressure, peripheral and central edema. And in more advanced stages will be hypoxia. No, though, most of the time, usually acute heart failure will present with hypoxia. Chronic heart failure is more subtle. As a matter of fact, will be often extremely difficult to detect unless you talk with the patient. Basically, you have to have, because you have slow development, then we have compensatory mechanism. I'm going to talk about those when we talk in the pathophysiology, like increased lymphatic function, The patients may look relatively asymptomatic. What happens, they learn over months and years to actually slow down and match their physical activity with what they can do. And they won't notice unless you can ask them to compare with, a year ago. Most of the time they'll be just, I'm just tired, weak, I don't sleep well kind of symptoms. And eventually they will stop eating, and then you figure that out. Basically, if you were to look then and listen to to the lungs, the rails are only present in about 15% of patients with chronic heart failure. As a matter of fact, often when a resident or a student, tells me, oh, I have these patients that I know is mine for years in heart failure clinic, and they come and say, oh, I heard bilateral rails all the way up to midway of the lung. And I said, ooh, are you sure that that's what you heard? And if you did, maybe this is pneumonia, it's not necessarily heart failure. No, something else is going on. And they can have weight gain. Hypoxia is really only in very advanced stages. Also, when you think about heart failure, what is acute and chronic, of course, we can look for signs and symptoms of the right side heart failure versus the left side heart failure. And, really, I put here just as a summary, this is more of for you to take home and read. It's not necessarily go over in detail right now. But bottom line is 80% of right side heart failure is actually due to the left side heart failure. And then you can have interesting lung issues, whether it's pulmonary embolism or COPD. And these patients with right side heart failure will be more objective. You can actually diagnose them from the door. They come with 20, 30, 40 pounds fluid overload, the ones that have most obvious congestion, whether it's in the belly or in the legs. They're going to have a physical exam that's predominant right ventricle heave, hypertrophy, split heart sounds, loud split S2 that's consistent with pulmonary hypertension. And actually, when you talk to them, they'll have symptoms mostly that affects that causes indigestion. They stop eating, they have early satiety, stomach fullness. Sometimes they may feel constipated. And really, if it's predominant right side, the left side symptoms will be only if their left side heart failure causes the right side. Most of the time, patients with right side heart failure, they're not going to be having symptoms of pulmonary edema. They may have symptoms of dyspnea if core pulmonary COPD has caused that. Now, if you look in the left side, it would be obvious offices. This is the standard patient that will have symptoms of left side heart failure, which is being most of orthopnea, paroxysmal nocturnal dyspnea. You can have also issues with low cardiac output. So if I were to summarize acute versus chronic heart failure, on the clinical side, the acute heart failure is clinical noisy, both subjective and objective. We can hear it, we can see it, patient can feel it. And it starts kind of suddenly. And on the chronic heart failure side, everything is silent, allows compensatory mechanism. A lot of our usual questions about symptoms and signs are actually going to be way underestimating. The answer most of the time would be no, and will be underestimate how sick is the patient, or including and particularly in presence of rails on the physical exam. However, the labs and the X-ray can help us to put everything together. For example, somebody with more of a chronic progressive heart failure, their BNP level, which is really a sign of neurohormone activation, the B-type natriuretic peptide is released by left ventricle, right ventricle in response to the heart stretch. It will be way more elevated in somebody like in the 2000 range, for example, as opposed to only 200 or 300. Somebody who has acute heart failure could be normal. Okay, so why? BNP tells you more about chronicity of the illness as opposed to acute part. Of course, it can go up with the acute, but it's more like what is for heart failure, what hemoglobin A1C is for diabetes. It will not tell you, hemoglobin A1C will not tell you what's the blood glucose in that moment, but will tell you what happened the last 2 or 3 months if the diabetes was controlled. On the X-ray, though, you're not, also on the labs, is more likely with chronic heart failure that you're going to have renal insufficiency. Why? Kidney is the biggest user of cardiac output from the heart. Its job is actually to keep an eye on the heart. So the first organ to go down when you have advanced heart failure is actually the kidney. And that's our sign that this is more advanced heart failure as opposed to acute heart failure. We have plenty of reserve. Usually, it's unlikely that you're going to have acute renal insufficiency. On the X-ray, obvious on the acute heart failure, you're going to see the typical butterfly-like pulmonary congestion, pulmonary edema, in general, the heart will have normal size because they haven't had the time to compensate and accommodate and enlarge due to neurohormone activation. While on somebody who has more of a chronic heart failure, you're going to have cardiomegaly, like Dr. Gupta has shown you on the X-ray. The heart silhouette will be at least half of all lung fields. And then you may have a little bit of evidence of congestion, mostly what we call cephalization. The vessels seem to be dilated and congestion on the top part of the lung. But more subtle things will be a small pleural effusion, or what we used to call Kelly B lines, basically lymphatics of the lung that seem to be preeminent on the X-ray, projecting perpendicular at the basis of the lung. And you will say, well, it's just a small pleural effusion, it doesn't really mean anything. Well, it actually means a lot. Means that you have exceeded the lymphatics capacity of the lung to accommodate fluid, and now it goes into the pleural space. Go ahead, Dimitri, I see there's a question.
So if you could go back to that last slide, there's
Sure.
a question relating to that last slide.
Sure.
It is, if you could try to explain again to the students, why wouldn't you have rails signifying pulmonary edema in chronic heart failure? And but before you answer that, I do also want to say, before we went live on the mics, Dr. Sorescu had said, you'll notice he has a lot of info on his slides, and I would encourage you to then not have to take as many notes and just listen. He's walking you through them. So I'll turn over that question. Why no rails in significant chronic heart failure?
Actually, I was planning to explain in detail. We're going to have slides dedicated for this on the pathophysiology side in the second part of the lecture. Having said that, there really it's, if you gradually accumulate, if it's chronic heart failure and you gradually start to elevate your left ventricular diastolic pressure or increase alveolar, or what we call pulmonary capillary wedge pressure, there's a tendency for the fluid then to accumulate in alveoli. However, if this rate of accumulation is slow, then starting forces in the lung will actually dictate production and proliferation of new lymphatic vessels. So remember, arteries come in, veins are supposed to get everything back out of the lung. If there is sudden pressure elevations on the venous side, whatever is excessive can be actually removed by the lymphatics as long as they proliferate and you allow time. This takes usually weeks to months to get there. So actually lymphatics drainage, related drainage in any congestion, whether it's in the lung or it's in the legs or it's in the gut, it's compensated for in chronic phase by proliferation of the lymphatics. They can go up to 10 times to accumulate more fluid. And that's the reason why you're not gonna see fluid in the lung when you look at the X-ray. Also in the belly, you may see ascites. That's the only way you can see on the sonograms. Most of the time, though, the patients will tell you there's got early ascites, but you have to ask for. When you see actually here a little bit of pleural effusion on the left, I always say this is a type, the tip of the iceberg. Don't be underwhelmed by, oh, it's just a little pleural effusion, we don't have to do anything else. That tells you that patient is decompensated, has exceeded the lymphatic capacity of accumulating all that fluid in the interstitium and now has to pour over into the pleural space. You know, fluid in the interstitium means not fluid in the alveoli. That's why you don't hear rails. When you listen and we hear rails, it's actually fluid in the alveoli. Once it gets out in the interstitium, the lymphatics, you're not going to hear that. And this is the main reason why incidence of rails in patients with chronic heart failure is actually less than 15% on those patients. More often than not, you should not hear rails.
Second question is, what's the difference between chronic versus acute and left versus right? Because the question is, does this mean that chronic heart failure is mostly a left-sided issue? And I think it's that both left and right heart failure, both can be chronic, both can be acute on chronic, both can be acute. It's not that chronic implies one side over the other. And I was wondering, what would you add to that? Because the question is, does that mean that chronic heart failure is mostly left-sided issue?
And the answer is no. When we say left or right, we refer to signs and symptoms how the patient reports to you, but also what is the possible original etiology of the heart failure. So if somebody started with an insult on the right ventricle, let's say somebody had a pulmonary embolism, somebody had a sleep apnea maybe, or COPD, the lung emphysema, then you're going to have your initial insult will be right side heart failure. That is a right side heart failure. They can present initially as an acute, can evolve to chronic, and then you can have bouts of acute on chronic on the right side. You can have the same on the left side if somebody had an etiology like a heart attack, high blood pressure does on the left. Or more often than not, anything that's chronic on either the left or right eventually will affect both ventricles because they work together. They're interdependent. Whatever happens to the right, you can start with the right side heart failure. Eventually, the left is going to be involved too, particularly in advanced stages. And the other way around, you see how I put here, if you can start with the left, but eventually 80% of all causes of right side heart failure actually is from the left. They work together, and sometimes you cannot separate. But I think here it's important, useful to separate each of a concept, and then you can combine them together in different clinical scenarios. I hope that answered the question. Okay, so now you ask me questions, and I'm gonna ask you questions, okay? Which of the following sign or symptom is least likely to be present in chronic heart failure? That should be easy by now. So patients with chronic heart failure, do they have leg edema? And the answer is they have. Whether it's acute or chronic, you can have that. Do they have an S3? Well, if it's chronic, yes, in general, if there's a patient who will have an S3, it's usually the chronic because it takes time to dilate and make your heart weak and overloading at the same time. It has to be congestion. These are the three criteria to hear a pathological thirst sound. Do they have dyspnea on exertion or at rest? And yes, patients with chronic heart failure will have it. How about lung rails on auscultation? And the answer is yes, this is the correct answer. You really have very low incidence of lung rails, as we mentioned, patient with chronic heart failure, as long as they're still relatively compensated. They don't have to go in the hospital, which then, once you have the acute on top of chronic, yes, they can have back rails because you just exceeded that compensation ability. And then you're going to have, again, fluid in the alveoli. And even if we get everything, until you learn and you develop your own clinical skills and how to ask the questions, just remember, a patient who has a BNP of 2,000, even if it looks relatively okay, it has way worse prognosis, more like it's chronic heart failure than somebody who has a BNP of 100 or 200 and has diagnosis of heart failure. That we know. All right, I hope this was useful. So we're going to talk more about pathophysiology of both acute and chronic heart failure. And hopefully that will allow us to understand better how to treat. And now, in the classic teaching, just like Dr. Gupta taught you and how it's in the textbook, is that you will have a really acute heart failure is an absolute or relative reduction in cardiac output, which does not match the peripheral tissue's metabolic demand. So it's a very cardiac output centric hypothesis and definition. Most of the time there's due to the impaired contractility, and actually I put here systolic heart failure, but it's true it's also in diastolic heart failure. In diastolic heart failure, although ejection fraction can be preserved, you have a relative failure to appropriate increase the cardiac output too. So you can have more cell reduction there too. And then you have a clear volume overload, what we call a patient who has congestion as a sign of the heart not pumping enough blood. But when we actually started to study this patient and we did invasive hemodynamics and measured their cardiac filling pressures and cardiac output and what we call systemic vascular resistance, we actually learned about half of these patients will have relative normal both ejection fraction, but also a relative normal cardiac output. Doesn't mean that cardiac output may not be relative low compared to what the body needs, but within the rules, it's relative normal. But what they seem to have all in common, whether it's systolic or diastolic, is actually an elevated systemic vascular resistance. In other words, that peripheral arterial faucet is closed, and they have elevated cardiac filling pressure, and there's clear redistribution of the volume into the lungs. So I would try to, in order to try to be more inclusive with the definitions of a heart failure, whether it's acute or chronic, really, we can redefine it nowadays as more of a signs and symptoms of heart failure with elevation, with evidence of elevated left ventricular and or right ventricular cardiac filling pressures. But this may be with or without low cardiac output. In other words, you don't have to have a low cardiac output to actually have acutely decompensated heart failure, as long as you have elevated evidence of signs and symptoms and evidence of elevated left ventricular and right ventricular cardiac filling pressures, whether it's by physical exam or by echocardiogram or a blood test like BMP. So this is more inclusive to help us actually to diagnose and treat properly the patients that we see every day on the clinical practice. And of course, we can then further separate with this definition in somebody who has a systolic heart failure. That means the low ejection fraction, less than 45%, is probably weak heart is what's causing this patient have elevated cardiac filling pressures and or low cardiac output. While if somebody has an ejection fraction at least 45, 50, then probably it's not the weak heart being the issue, the initial part, but it's actually the elevated cardiac filling pressure, heart having to, has impaired filling basically. And so you notice often these are different scenarios of etiologies, how this happens. You can have a dilated heart, high blood pressure, ischemic cardiomyopathy on somebody who has low ejection fraction. Often they will be with a positive S3 because remember, this requires, a positive third sound requires a big floppy heart with congestion, all right? And while somebody who has more of a diastolic heart failure, you know, they usually a hypertensive cardiomyopathy or hypertrophic cardiomyopathy. What they have more often than not is actually a fourth sound. The fourth sound is basically the sound is triggered by the strong atrial kick that has to empty at the end of diastole against a stiff left ventricle. So that goes more with increased afterload kind of conditions as opposed to S3, all right? And PMI in general is not displaced. And of course, this definition for acute heart failure will apply the same way. So questions now. We have if both acute systolic and diastolic heart failure have everything in common except, all right, what they have. So do they have elevated cardiac filling pressures? Are they supposed to answer? I wait for their answer, or then I just can go over each and every question? I'm just, or I do just go over each answer and explain. Okay, all right. Okay. Okay, so I hope you thought about this, but basically, remember the universal, if you really want to be all-inclusive and get everybody with heart failure, it doesn't matter systolic, diastolic, acute or chronic, then what they really have in common, other than signs and symptoms of heart failure, is actually elevated cardiac filling pressure. So they all have in common this, okay? Just having elevated cardiac filling pressure doesn't mean you absolutely have heart failure because you still need the signs and symptoms, but that's important. What they do have, for example, the only systolic heart failure will tend to have a positive S3 because remember the requirement for that, it's a dilated heart with that is also weak with an ejection fraction, usually less than 35% with congestion. That means the cardiac filling pressure have to be elevated. So S3 in general is specific for a systolic heart failure, while S4 is more likely to be in diastolic heart failure. And yes, the others, the elevated systemic vascular resistance, it's obvious will be present just like elevated cardiac filling pressure is actually one of the mechanisms in this setting. We know there's neurohormone activation, and then because of this vasoconstricting neurohormones, the systemic vascular resistance is going to go up, increase the afterload, and aggravate actually the cardiac filling pressures. Lung rails on auscultation, it doesn't matter whether it's systolic and diastolic. Remember, they actually relate more with the acute versus chronic presence of the congestion. And so, of course, they will be both present. And then elevated BMP, yes, can be happening both in systolic and diastolic. It is more likely that you're going to have elevated, a higher BMP in somebody with systolic heart failure than in a diastolic heart failure. But if it's elevated, it will definitely tell you there is heart failure there. In general rule of thumb, for a given systolic or diastolic, the BNP actually is going to be elevated about 3 to 5 times more in systolic than on diastolic. And this has something to do with actually the perceived wall stress in the heart. So even the same 20 millimeters mercury of elevated LDP, when you put that in formula in the Laplace law, a thicker heart will be more protective from the heart releasing BNP and perceived wall stress than a thinner heart, wall thin heart. And that's why BNP goes way higher in somebody with systolic heart failure as opposed to diastolic heart failure. Okay, so how about our particular patients here? We talk about this. How can I summarize after we went through all this with you? Well, first of all, in order to call it either systolic and diastolic for this particular patient, I'll have to have an echocardiogram. And you know, actually here to the what you see on the right is actually the actual echocardiogram of our patient. And what you notice is there's not only you know, compared to the left, which is a normal, you see how hard squeezed it in, what we call an ejection fraction of 65%. Here it seems to be dilated, a little floppy. There's a little bit of thick left ventricle. We have usually the wall is at least 1.1 centimeter. That's on the left, on the thick side. And also, you see how irregular the heart beats? That's her atrial fibrillation, or you know, going in and out of it. But in this particular view, actually, she was in sinus tachycardia, sinus rhythm, but she's had atrial fibrillation on presentation. So the echocardiogram was read as an 11 degree ejection fraction of 25%, which placed her of having systolic heart failure. She had some right ventricular involvement already. She had some dysfunction there. She had a stage 2 diastolic dysfunction, which means you have some elevated, chronic elevated left atrial pressures, and she has a little bit of concentric left ventricular hypertrophy, telling you that this heart has seen for at least 10 years probably some high blood pressure increase after load. And this was our EKG that showed atrial fibrillation on presentation with rapid ventricular rhythm. Go ahead, Dimitri. I see there's another question.
One student questions about how on Monday they learned that for ACC heart class A, the patient is at risk without actually having structural heart disease or symptoms of heart failure. And I would even add to that for class B, they have structural heart failure, but no symptoms.
Correct.
So how is it that high cardiac filling pressures wouldn't be enough to diagnose somebody with class A or B heart failure, even with no signs or symptoms?
It is because, particularly if it's chronic, as I mentioned, you can have compensatory mechanism which actually are designed so you don't feel it. So you can have in stage A, you know, yeah, so if we go by stages, and by the way, this is an excellent question. As a matter of fact, the whole purpose why they developed the stage A, B, C, and D classification is to particularly to answer this question. Because we know that symptoms, they only come late in the disease. Somebody can have extremely advanced heart failure, and actually his first visit we see in the hospital, we actually put them on inotropes and we give them a heart transplant in a month or two. And somebody can have, if it happens extremely slowly and over time, and they could have been perfect asymptomatic up to you know, a week prior to presentation. And yes, that they had chronic elevated cardiac filling pressures for years. They just learned to adjust, particularly if they are, for example, you say, well, how can that happen? It's very simple. Somebody's extremely active with exercise. You run for an hour for 20, 30 years of your life every day. You're going to have excellent compensatory mechanism. You may not fail. You're going to be in good shape and fit not to feel those signs and symptoms of heart failure. The neurohormone activation is going to be well toned down for you. And that doesn't mean you're not going to have eventually an ejection fraction of 10, 15%. And so prolonged phase of asymptomatic follow, which can only be diagnosed if usually this stage B is diagnosed because incidentally you come for a doctor for other reason, and then doctor hears some rails, or you know, you come with a cough and cold, and you say, hold on a second, it's not a cough and cold what I'm hearing here. Somebody listens to a physical exam, and then you're going to find actually an ejection fraction that's reduced on an echocardiogram when the doctor orders. Or you come to have you're 60 years old, and you know, you have a low high blood pressure, and need pre-op evaluation for some other surgery. We get an echo, and then we see, hold on a second, your ejection fraction at 30%. Doesn't mean we should test everybody with an echo no matter what, because it can be this asymptomatic phase. No, that's why we start with risk factors, which is the big three: coronary disease, diabetes, and high blood pressure. And we aggressively treat that because we know we can prevent, we have evidence-based medicine to, if we treat those aggressively, we prevent new onset heart failure. If that's not well compensated, if you start to have subtle signs or symptoms or anything else, we're gonna, or if you go for a pre-op evaluation, we're gonna do the echocardiogram, and that's the proper way and cost-effective way of actually diagnosing it.
I think if we are strictly speaking, people with stage A and stage B heart failure do not have clinical heart failure yet.
Yeah.
They haven't presented with the clinical symptoms that you saw with Dr. Gupta's Framingham criteria for heart failure. So they haven't progressed to the point of having a clinical diagnosis of heart failure, but they have either the dysfunction or risks for dysfunction. And that's a little confusing, and even doctors sometimes will say somebody has heart failure when their EF is 40% or 35%, even though they've never had symptoms. We'll still say they have heart failure. So we're not great about delineating people who have had symptoms as being the only ones who we call having heart failure. So I think it is good to distinguish between whether somebody's having clinical symptoms of heart failure and the clinical diagnosis of heart failure based on symptoms, or they're also having it because of their risk factors or structure. So class A, or sorry, not class, stage A and stage B heart failure, it is fair to call those heart failure even though they've never had the clinical symptoms of heart failure.
Also, and the excellent points. One thing is important. This stage B is where we have the gray area, and we say, well, patients are asymptomatic. Honestly, nobody is asymptomatic. This is the ugly truth. It all depends how far we push it. If I really want to know, I got somebody, patient comes to me, it's got, oh, somebody did a test on me, ejection fraction at 35%. I look at the echo, it's real. And he says, I absolutely refuse to believe I have this diagnosis. I just put them on the treadmill, and then they will show you. We have objective ways how to sort that out. Don't worry about it. And if somebody, all they do, they have a job where 12 hours a day, they just sit in front of the computer, you can have extremely advanced heart failure before you're going to be symptomatic while you're just sitting at your computer. So that doesn't mean anything. All right. But I do believe it's an extremely useful classification, thinking as stages of progression, because we know there is progression. We know, we know that if we intercept each and every stage, we actually can stop and reverse and improve survival and mortality in these patients. We have the evidence-based medicine. Now, for this particular patient, I put here a whole list of things that we do if you see somebody with new onset heart failure, which you can go, length at home over it. Right now, I'm just suffice for this particular patient. Basically, the single most important test that we really needed, all the others were normal, was actually some kind of evaluation. The patient does not have significant coronary disease to explain this new onset acute systolic heart failure. So we did a cardiac PET when she was in sinus rhythm that shows she has normal. There wasn't any reversible ischemia. So basically, we could easily now classify this patient as acute on chronic. Again, this has been going on for months after you talk to the patient, decompensated heart failure. She's a stage C because it's B plus symptoms. It's typical symptomatic patients with heart failure, even if it's new onset. Class 4 when she presented. And if I were to think about the etiology and structural part, she had seen signs and symptoms of both left and right side heart failure. And it was non-ischemic because we don't have any coronary disease there. And if I were to look back, how did this happen over years? Probably she is 68. She has had long-standing, probably mild hypertension, was not diagnosed. As a matter of fact, she was on a little bit of blood pressure medicine, but every once in a while she will take it, sometimes she won't. And then after 10, 15 years of this, she's 68, she's a little more stressed out, you can go in atrial fibrillation, and that by itself can cause after 3 or 4 weeks what we call tachycardia-induced cardiomyopathy that suddenly would depress both the left ventricle and right ventricle function. So this is exactly what happened to this patient. Go ahead, Dimitri.
Will you tell them what RVR means?
Rapid ventricular rate. Sorry for that abbreviation. Yeah. All right. So now we got 20, 25 more minutes. So I show you how the patient presents. I show you, How is it going to be different in acute versus chronic? Now, we put some light into what's happening with this patient. The big question is, how are we going to treat this both? First of all, we got to get this patient out of acute decompensated phase of the heart failure. And in other words, things that we need to do in the hospital. And second, we have the chronic heart failure part, which is things that we need to do outside the hospital shown to improve mortality and improve the ejection fraction for this patient. In order to sort that out, we got to figure out, okay, I like this scheme because it tells you really this is how a normal heart should look like working under normal pressures. On the left side, the pressures in systole should be 125 and diastole should be 5. On the right side, the pressure should be 25, about 5 times less than and on the right side than on the left side, right? So, and these are the pressures in the lung. And you see, no matter what you do, whatever is happening, the blood flows from a higher pressure to a low pressure. And this gradient has to be maintained through a proper heart pump function. Now, if you were to look at, it doesn't matter whether it's acute or, whether it's left or right side heart failure, eventually a lot of our patients, it doesn't matter what's the etiology, they're gonna look like this. Pretty much if you actually look over this, I just put in one graph, every single condition that can cause heart failure here, okay? But at the end of the day, it will be the same. Either chronically, you're gonna elevate your left side heart pressure, that means the LVDP is gonna be 20, with or without low cardiac output, because the left hand pump is gonna get low on top of elevated cardiac filling pressure. Or you're gonna have elevated right side high pressure, that means the right ventricular and diastolic pressure will be, instead of 5, will be 20, or you're gonna have low cardiac output because the RV dysfunction. And of course, if it's a predominant left side insult, the predominant pressures will be elevated on the left side initially. Eventually, you're gonna get your right side pressures elevated, but never as bad as the left. Or the other way around, you have a primary insult on the right, your right side pressure will be way more elevated chronically than the left, but eventually the left are gonna start to get worse too, all right? Or you can have, but what really matters is I got a heart in the middle here. Question is, why is the heart, whatever is the original insult, has to elevate the cardiac filling pressures? And the answer is chronically. And the answer is, you don't need to look at the heart, why the heart is elevated pressures. You got to look at the periphery, because the periphery is going to have a demand. It's going to activate certain mechanisms to try to get the heart output more once it senses what's happening. And basically, we're going to go over the next 5 minutes, how does heart get from really normal cardiac filling pressure after it had a certain insult to chronic heart failure with elevated cardiac filling pressures with normal high or low cardiac output. And the low cardiac output theory part really comes only at the very advanced stages. I know for simplicity to explain the concepts, particularly first time you hear this, we always start heart failure, it's all about low cardiac output. That triggers everything. Really, that's not what it is. That's only in very advanced heart failure. What really happens actually in early stages of heart failure, and I use this slide from Dr. Gupta because I think it's extremely useful. But bottom line is, I added my little thing here. She started with the low cardiac output causing everything that the kidney and the brain is going to react to. But the truth is elevated cardiac filling pressure is the first that triggers actually some kind of perfusion disturbance at the kidney, who, remember, his job is to keep an eye on the heart because you get about 20% of the cardiac output that goes into the kidney. Once the kidney starts to be abnormal, it's going to release neurohormones like angiotensin. Angiotensin comes from angiotensinogen made by the liver, who is going to be converted by renin once activated by once the kidney senses the heart is not doing well, releases angiotensin, and angiotensin in turn will actually release aldosterone from the adrenal gland. And look what happens. And acutely, these guys actually don't do much. They actually release only after weeks to months of acute heart failure. You need to go towards chronic heart failure to release these hormones. And what happens is, once you release those, what does angiotensin do? Angiotensin has acute hemodynamic effects. We know about the vasoconstriction, right? It's going to try, it feels like, oh, my blood pressure is low, I need to raise the blood pressure. So it's going to cause vasoconstriction, both in the kidney and in the periphery, that will raise actually the blood pressure, temporary, okay? It has a compensatory mechanism. Also, through the aldosterone, will retain sodium and water that will also increase the volume status and will raise the blood pressure. So the first intention is we're gonna compensate here. The catch is though, on long term, angiotensin is also, it's a growth hormone. Really in the fetal life, the main way how we actually increase our heart, we grow our heart, our vessel, our kidney is because angiotensin is extremely potent growth hormone. And this growth factor will cause cardiac hypertrophy. This is the reason why chronically heart gets big and floppy. And that allows some compensation so we can maintain the cardiac output, as a matter of fact. Unfortunately, a big dilated heart also has completely different cardiac myocytes than a normal healthy heart. These are what we call fetal cardiac myocyte phenotype, which is adapted for low oxygen state in the fetal condition, is not adapted for high pressure system in the adult life. Remember, in fetal life, the pressure is only 25 millimeters mercury, like right-sided, is not 100 like in the left side. So basically, while adapts allows to compensate for cardiac output, on long-term actually is deleterious because a bigger heart has increased afterload and will progress by itself. Also, the aldosterone that is released will also cause, if you will make proliferate the fibroblast, the other element in the heart that causes cardiac fibrosis. And with time, the difference between reversible and irreversible is actually the presence of cardiac fibrosis. All right, now, last but not least, we're really the one that coordinates all these activities, believe it or not. Our kidney is just trying to do its job, but really everybody answers to the boss, which is the brain. All right, so the brain, either through baroreceptors or chemoreceptors, or from the angiotensin release from the kidney, is gonna find out that the heart output is not adequate initially during exercise, and then eventually during at rest in more advanced class 4 heart failure. And really the brain is gonna release the most powerful neurohormone yet that is designed for us to run, to run a marathon, which is the adrenaline, the sympathetic system. The sympathetic system, while it puts pressure on the heart, will cause tachycardia, will increase some inotropic effect. The problem is that it's constant. It will also work on the kidney in causing more renal vasoconstriction, and will start with time to actually shut down the kidney. And pretty much brain now starts to pretty much make the heart and the kidney look like enemies. They're actually fighting at each other at any given time. The purpose is to preserve a status quo of heart providing enough cardiac output to the brain. Unfortunately, if it's acute, like when you run a marathon, this is great. Our heart can sustain that level of adrenaline if you run a marathon, because we always take a break and we stop. Eventually, everything recovers. But imagine that you have adrenaline like you're running a marathon for 24 hours around the clock for weeks, months, years. As a matter of fact, adrenaline at that level that we measure, we know for a fetal heart phenotype is extremely poisonous. The fetal heart is also more sensitive to adrenaline. And with time, this elevated adrenaline sympathetic activation actually causes further cardiac myocyte loss and apoptosis, even if you don't have any other new insult on the heart. So you can see how all this happens in the background through this chronic activation of neurohormones that's pure related by a very complicated deleterious relationship between brain, heart, and the kidney. And you say, well, neurohormones, but we don't measure them. What's the point of talking about this? Yes, we have proven this in the research clinical trials in the last 40 years, but we don't measure them. Yes, you do. It's called BNP, or NT-proBNP. The B-type natriuretic peptide, as a matter of fact, is the one the heart in exchange will release its own neurohormone. Hold on a second, you guys are squeezing me too hard. I need to cause some vasodilation. I need a break from time to time. I need some natriuresis. And that's how the heart reacts in response to this deleterious neurohormone activation by releasing BNP. So yes, we measure BNP, and once again, you see why a chronic elevated BNP, the higher the level, the worse the outcome in these patients with advanced heart failure. So keep that in mind. Yes, question?
So if aldosterone and angiotensin II release characterize chronic heart failure, can you explain the compensation in acute heart failure?
Okay, very good point. And Well, bottom line, that's the whole point, is not compensated, it's decompensated. So as a matter of fact, we're gonna go over these stages. There is the patient presents to emergency room because he's not compensated. He's gonna have flash pulmonary edema, you're gonna have hypoxia. There's nothing to prevent that. It needs help. And what happens is we compensate the patient by using diuretics. I'll show you by using vasodilators, trying to normalize the systemic vascular resistance and the congestion. But in terms of the mechanism, they're activated in acute heart failure with the intention to compensate, right? So the question was, clear, we have the other guys, renin-angiotensin, aldosterone, and eventually adrenaline is activated long term. What about acute? What's the brain and the body doing for acute to try to compensate? And that's probably the question. And the answer is only the brain can acutely work so fast within minutes to hours, okay? And that's actually pretty much what I showed you, the adrenaline. The adrenaline is the first to trigger, get activated, the sympathetic activation. You get, and then you see the dramatic component of acute heart failure symptoms. That's why the patient is breathing fast, is short of breath, is tachycardic, is sweaty, it's cold. That's adrenal activation. Unfortunately, more often than not, that's actually still deleterious because it's like somebody's already running and you need to give a break, but actually make it run more. Somebody just ran a marathon, is about to die, and this adrenaline is telling you, no, you need to run. That's how you're gonna fix this. So actually, most of those are deleterious in those phases. That's why what we do the opposite. We give them oxygen, and we give them actually some morphine to relax, calm down that adrenal activation, sometimes even beta blockers. So it's deleterious, but that particular insult, that adrenal activation is actually what triggers on long term once we help the patient in the clinical compensation part, that in 2 or 3 weeks, then in the background, renin-angiotensin, aldosterone are going to start to activate. And so that we want that adrenaline signal actually to be turned off. And that's what it does. That's why for years, months or years, we can be compensated, adrenal signal is off. Only at the end stages, the adrenal signal will come back again. And that's usually signals irreversible process. Okay.
What's confusing a little bit is that the initial things that the heart does after its insult are compensatory to maintain cardiac output and to maintain perfusion pressure. And all those mechanisms in the last slide to compensate over time lead to decompensation when the heart can no longer manage against the high afterload and the high preload from all these systems. And so then you end up with decompensated heart failure because of all these internal mechanisms of compensation that are in place to try to maintain those, the perfusion pressure. And in order to get out of that decompensated heart failure, we have to lower filling pressures again, lower afterload again, and we'll refer to that as compensated heart failure when through changes in using medications and lifestyle, we can keep the normal internal compensatory mechanisms for going too far. So that's,
Right.
yeah.
What we really try to do is actually convert of acutely decompensated heart failure into a chronic compensated heart failure. That's pretty much it. But yes, Dimitri, that was very useful. Thank you. So so I told you what triggers this neurohormone activation. We got to think that way. And what triggers the tissue? It's very simple. The tissue is the boss of the heart, every single tissue in the body. And in a nutshell, this is what happens in every tissue. You have an arterial pressure at the capillary level is about 25 millimeters mercury. You have a venous pressure, it's about 5. These are the Starling forces. This is not Frank's Starling law. This is the Starling forces that guide the perfusion. And in general, you have a tissue pressure gradient, in other words, the arterial component is about 8 to 50 millimeters higher than the venous element. And then you really want whatever comes in to come out. Usually less than 1% will be remaining in the system that is removed through the lymphatics. So that's a normal Starling forces. And then remember, kidney is the sensor. I do need to tell you what's happening with the Starling forces in the kidney too, because that's the one that triggers all this renal hormone activation. Now, kidney is a little more complicated. It's got 2 capillary beds. It's got 2 faucets, so to speak. One is the filtration part. You need to look at the glomerular. The other one is the reabsorption part. So basically, kidney functions by throwing everything away and washing it out. And then we got to recover at the end in the reabsorption, 95% of what happened. And because we have 2 capillary beds, we have 2 different Starling forces here. The first set of stalling forces that pushes everything into the tubular system is the glomerular filtration. That depends on a pressure gradient that goes from 60 to about 30. So you have overall actual net filtration pressure after you do all the math. Again, this is in Guyton, about 10 millimeters mercury. Now, at the other end, when we want to reabsorb everything back that was useful, you actually need a net reabsorption pressure about 10 millimeters mercury. All right, I'm not going over every detail because it's irrelevant here. But what is really relevant, you need to realize, for this system to work, you can intercept and cause kidney trouble either if you have an issue with either the pressure being here low, pressure being at the afferent arteriole being high, or pressure at the capillary venous level being high. So if either this goes up, this goes down, goes up, or this goes down, you're going to have problems with the kidney either having issues with glomerular filtration rate or with venous congestion. And that is how the kidney senses actually there is a problem with elevated cardiac filling pressure and or low cardiac output. All right, we need to maintain that. So what happens now if you have acute heart failure? There is no compensation. Then suddenly this arterial capillary pressure it will go down, less than 25. Your venous pressure and starts to go up. So then your pressure gradient filtration rate is going to go down to 5. In other words, you're going to have stuff that will come in, but it won't go out. All right, and if it doesn't go out, you're going to flood your organs. Whether you're going to flood them and probably the most important organ that makes you go to the emergency room will be your lungs. That's when you start to have fluid in the alveoli, like we talk about. That's when you start to have hypoxia because oxygen exchange is going to be impaired. And that's when you're going to have here rails on the physical exam in acute heart failure, or you're going to see the pulmonary edema on the x-ray. That's decompensated heart failure and acutely. Now what happens if you have chronic heart failure? Okay, guess what? That's where kidney comes into place, okay? Kidney is going to start sensing. It has a special sensor, this juxtaglomerular apparatus, where it's basically the distal tubule right at the beginning gets in touch with the glomerulus, and it has cells that can sense either the sodium load, the volume load, or the pressure load, whether it's the mean arterial pressure in afferent or efferent arterioli. And each time these are changed in an unfavorable way that will reduce the GFR, is going to actually activate the macula densa to start to activate renin, will activate angiotensin. Angiotensin really release acutely. It actually will start first working on the efferent arterioli. And remember, it's like you're raising the dam, so now your GFR is maintained. Actually, it makes sense. This is compensatory to maintain, by all means, the glomerular filtration rate. The catch is, long-term, this angiotensin release will actually also cause sodium and water retention. Actually, angiotensin per cell can cause proximal reabsorption of sodium and water. Eventually, chronic angiotensin release activates aldosterone, which will cause also sodium and water retention from the distal tubule and collecting that. And with time, at higher level of angiotensin 2, you're going to have also vasoconstriction of the afferent arterioli. So what it looks like this nicely, you see, you start to increase your vasoconstriction here on the efferent arterioli to maintain the GFR, and you do maintain it up to a point. But once it gets three times higher than normal, actually the GFR eventually is going to go down. But what you notice, the first moment you start to increase your renal arterial resistance, you're going to reduce the overall renal perfusion. So any kidney that has seen heart failure, congestion, elevated cardiac filling pressure is not, even if we don't clinically, the BUN and creatinine stays normal, they're actually a kidney that are underperfused to begin with. Any kidney that works with that. And so there is what we call asymptomatic subclinical stage of actually renal dysfunction, although we don't see it because it's defined by impairment of the renal blood flow. So you see, even the intentions to maintain GFR actually lose your, you get vasoconstriction and kidney gets underperfused. And it's actually sacrificing itself for the brain. It says, well, I'm the biggest user of all this volume. Let me turn myself off so I can have more for the brain, which is okay in acute situation. You're dehydrated, you're losing blood, but chronically is not okay. All right, so question. Activation of the angiotensin 2 in chronic heart failure, causing the following, except it causes renal afferent arterial vasoconstriction, Does it cause sodium and water retention? Does it cause elevated systemic vascular resistance or systemic arterial vasoconstriction? Does it increase renal blood flow? Does it increase glomerular filtration rate? And yeah, okay, great. Thank you. And really, the answer is it does all of those except the increased renal blood flow. I just showed you the slide that the moment you activate the renin-angiotensin system, kidney does everything as the above, trying to maintain the GFR. That's this purpose, but it reduces the renal blood flow. Okay, there is no free ride. You're gonna have to, once you activate angiotensin, you get the kidney involved, the kidney function is gonna go down, period. Doesn't matter. And the only way you can get away from that if you stop that, if you treat whatever is causing that angiotensin release. All right, good. So now, what's the good news and the bad news about? Well, the good news, kidney is releasing angiotensin, okay? But the same angiotensin, once it gets to the tissue on chronic condition, and that chronic sodium leak now in the rest of the tissue actually starts to stimulate the proliferation of the lymphatics. So the way the body compensates in every level, whether it's in the lung, in the gut, in the other tissues in the kidney, is that these lymphatics, once they see the sodium is leaking and there's of blood into the tissue as opposed to being neutral, then we'll activate the lymphatic proliferation about 7 to 10-fold, and we'll try to get the sodium and water back and decongest those organs, and lymphatics drain into the right atrium. Okay, so as long as your right atrial pressure will still stay low, okay, that means it's still in early stages of heart failure, then this system works just fine and compensates. And this is the true answer why, as long as you give time, and this is chronic, well, the body will take care of compensating it by itself, as long as your right atrial pressure stays below 10. So the lymphatics have a place to go, basically. All right. Now, what happens is lymphatics are not. Eventually, you get decompensating. Eventually, the right atrial pressure starts to go up. Then you have further the final killer, what I call it, in the system. The further neurohormone is really activated again. You see, the heart does not like adrenaline. There's all this, what you see, we activate long-term renin-angiotensin to try to shut off the adrenaline system for a weak heart. Now, the system is decompensated again. Now you're gonna have adrenergic system is activated. It does everything that's supposed to be wrong for the heart, and although much faster than renin-angiotensin. Whether you activate this by elevated cardiac film pressure, plus minus low cardiac output, whether you activate this because the brain senses through the chemoreceptor it doesn't have enough oxygen, or you have elevated cardiac, where you have edema and congestion. The the increased sympathetic adrenergic drive, whether it's directly through nerves into the kidney or into the muscle, causing vasoconstriction, or indirectly through the epinephrine release from adrenal gland, is actually extremely deleterious for the patient with heart failure. And pretty much, this is a more simplified version of this. Go ahead. Dimitri, question.
Question is, can you explain the relationship between the lymphatics and the right atrial pressure?
Well, all the thoracic lymphatic duct, the final, everything drains into the thoracic lymphatic duct, which drains into the left subclavian vein, which drains into the brachiocephalic vein, which drains into superior vena cava, and into the right atrium. The lymphatics pressures are in the 5 to 10 millimeters, actually 5 at most millimeters mercury. So as long as it can go into a right atrial pressure is below 5, then the lymphatics will be able to compensate and really get all the fluid that was excessive in the tissue back into the right atrium and keep the tissues out of congestion and edema. But once the right atrial pressure, patients either from the left side heart failure, now you develop right side heart failure, or you have another insult on the right side. Let's say somebody gets acute pulmonary embolism on somebody with left side heart failure. Then the right atrial pressure starts to go up. Suddenly, this lymphatics got no place to go, so you are more likely to actually visualize the peripheral edema, whether it's in the legs, whether it's in the lungs, they're gonna get pulmonary congestion again, or whether it's in the gut. Yeah. So this is a summary slide that, at the end of the day, for chronic progressive heart failure, it requires one or another this chronic neurohormone activation, okay? That's originally triggered by actually elevated cardiac filling pressure, not necessarily low cardiac output. Even if there was initially low cardiac output, we compensate them, remember, and then we switch them to chronic. But this persistent neurohormone activation actually will trigger two mechanisms. On one hand, sodium water retention, plasma volume expansion, and more elevated cardiac filling pressures. On the other hand, increased vascular resistance, vasoconstriction, elevated systemic vascular resistance, which again will increase the afterload at the left side of the heart or right side, and will eventually is going to drop the cardiac output. And then this cycle continue on and on. Once you have also elevated right-sided pressures, right? Now we have major impairment of the renal function because kidneys don't just have the arteries, they have also the vein. Remember that second filtration reabsorption force, that gradient of 10 millimeters mercury is supposed to reabsorb everything back into the kidney. That purely depends on the renal vein pressure being less than 5-10 millimeters mercury. Once the renal veins drain the semi-lining lymphatics into the right atrium. So if your right atrial pressure goes from 5 to 20, then your renal vein pressure has to go from 5, 10 to 30. And that's going to tremendously now irreversibly impair the GFR. Now we get what we call renal insufficiency in somebody who has chronic heart failure. And this is a sign of extremely progressive heart failure and very advanced. All right, and of course we give diuretics, which on one hand will help the patient to decongest. On the other hand, believe it or not, aggravates this neurohormone activation on long term. All right, so if I were to go through now, how do we put this into perspective of what tools and what medicines we have to help these patients, both in acute and chronic heart failure? So in acute heart failure, really, the goal is compensate the patient back, okay? Get them out of the decompensated stage. What decompensates them is congestion. So you gotta decongest them. What decompensates them, they have elevated systemic vascular resistance, increased afterload, so we're gonna give them some, vasodilators, and I'll show you how that changes the Frank-Starling curve. And if they have some inappropriate tachycardia, like atrial fibrillation, the heart beats so fast that diastole is impaired, the heart doesn't have enough time to fill, we're gonna have to knock that down and do something about it. Sometimes we use medicine, sometimes we use electrical principles, what we call cardioversion. But that's pretty much the main goal of acute heart failure. And sometimes what we do for acute heart failure may be actually opposite what we do for chronic heart failure. For example, if the patient in acute setting has also evidence of low cardiac output, we may use actually inotropes. We may use the butyramine and Mirinon just to get them out of that particular stage in that particular moment to compensate them. But we know that these inotropes actually long term, while they may be useful short term, long term they're actually deleterious and further contribute to progressive heart failure. So we don't want them to be on long term of that. Could be the short term. And here's why we need to really decongest and why we need to normalize the afterload. Here is the over 100 years old Frank-Starling curve. And my job is to teach you what's been there for 100 years. Because no matter what, if it's been there, we keep repeating, that means it's going to stay with us. And here is, it looks complicated, it's actually extremely simple. Every patient I ever see in the hospital, in my mind, I use this as a virtual framework. For example, if you have a normal heart with a normal ejection fraction here of 65%, okay, then the higher the cardiac filling pressures, and I put here some numbers, arbitrary number, it could be either right or left, it will be the same, is between 10 and 18 millimeters mercury. In other words, once it gets to about 18 millimeters mercury, the maximum, that's when I have the maximum cardiac output from just how much blood I have put into that heart, okay? And, you may have sometimes, if you overstretch and you give more, elevate more cardiac filling pressure, somebody with normal ejection fraction, it may or may not drop the cardiac output, but you're gonna have symptoms of actually of congestion and elevated cardiac filling pressure, like flash pulmonary edema. So you don't get there. But a heart that's weak and what we call big and floppy, that means a dilated heart with 11 injection of 35 at 25, you see how the shape of this curve becomes more of a bell shape. So suddenly, your point of maximum relationship, if you look at this line, is no longer at 18. It actually favors lower cardiac filling pressure, 16 or so. This is irrelevant you just need to understand the direction that a heart like this will not like elevated cardiac filling pressures. And why not? Look what happens, our patients, all right? Because if your wedge pressure is over 18, then by itself is gonna actually drop the cardiac output. You need to decongest the patient so I can get them compensated. Volume by itself in acute heart failure will actually lower the cardiac output. So that's one goal of the therapy. I want to optimize that relationship for this weak heart. The second role of acute heart failure therapy is actually to normalize the afterload. That's not given by the Frank-Starling curve. That's given actually by the Laplace law. So what the Laplace law says is that pressure inside the heart, that means your afterload, is direct proportional with the pressure ahead of the heart, which here the equivalent will be the mean arterial pressure, right? So you have a mean arterial pressure, or when we measure in absolute terms systemic vascular resistance, which is really the mean arterial pressure minus CVP, times 80 divided by cardiac output. But bottom line, the main variable that doesn't change is the mean arterial pressure. So if you look at that, here for this particular patient, a map of mean arterial pressure of 88 it's actually causing a systemic vascular resistance 2,000. The normal one is about 1,000. I know if you look in the text, we can have ranges, 700 to 1,200. Ignore that. Just put 1,000 because it's impossible to compare. So 1,000 is normal, for the purpose of this exercise here. Let's assume that I'm going to try to normalize the systemic vascular resistance from 2,000 to 1,500 and then eventually to 1,000. Okay? Look what happens, the impact of normalizing the afterload according to Laplace law on this cardiac output. Even I have the same ejection fraction of 15–20%. Okay, even with the same elevated cardiac filling pressures. If I normalize my afterload, actually all this curve, the blue curve, is going to shift parallel up 2 to 3-fold, increasing the cardiac output 2 to 3-fold, if I can correct that. So this is extremely important. And now you can see why chronic neurohormone activation of vasoconstriction that's caused by angiotensin or by norepinephrine is actually deleterious for these patients, whether they are acute or chronic heart failure. All right. And so if I normalize this, then I can get patients to have increased cardiac output, even if temporarily they can be congestion and have some suppression of cardiac output. And every once in a while, if the mean arterial pressure is actually like this patient of ours was actually on the low side, was in the 70, I can't really add a vasodilator because SVR not elevated. So I'll have to support the heart with an inotrope. And if I were to add the butyramine here, then it's going to do somewhere in the middle. So all this, well, all I do with all these agents in acute heart failure, either I try to reduce the volume, decongest to improve the cardiac output. Either I try to normalize the afterload by increasing cardiac output, you see, or I try to move the curve to the left, temporary with inotropes. Why I need to increase the cardiac output is very simple. If you don't have adequate cardiac output, the kidney is going to refuse to behave. It's going to not going to cut down that neurohormone activation. It's not going to diurese. So I need first to improve the heart hemodynamics so then I can improve my kidney perfusion. So then kidney can let go and let the other medicines do their job. All right. So, and you can, well, what I like to say is if I see in this patient with acute heart failure, a mean arterial pressure is around 70, then I'm happy with that. But if I see the mean arterial pressure starts to go up, that's my clinical surrogate that my systemic vascular resistance is high. Actually, 2/3 is because of actually the kidney, renal vascular resistance being high. But also when I touch the patient, it's cold peripheral, and I know is the skeletal muscle is not getting enough blood supply, SVR is too high, or cardiac output is low. And really, if we were to put in perspective, this is a clinical classification of patients who come with acute heart failure, developed by Dr. Stevenson, over 30 years ago. A patient that we can assess congestion at rest. If the patient is dry, I don't see any volume overload. If the patient is wet, this will be on the horizontal axis, and then I can assess perfusion at rest. The patient could be cold at rest or could be warm at rest, and really and then I can call them either warm wet, cold dry, warm dry. Of course, warm dry, they're compensated, they shouldn't be in the hospital. Most of the patients come to the hospital on the warm wet side. We just need to decongest them most of the time. Now, what's the evidence of low perfusion? Probably the single most important and objective will be what we call narrow pulse pressure. A systolic minus diastolic divided by systolic less than 25%. Sorry, it should be a denominator here, divided by a systolic less than 25%. That's easy. So you see what we call a narrow pulse pressure. Systolic pressure normally is 100/70. Well, what if it becomes more like 110/90? That's narrow pulse pressure. You know, and of course you have cool extremities. Usually they'll be intolerant to any kind of medicines drop the blood pressure. They have more renal dysfunction. They could be sleepy, and they have low serum sodium. So obvious, we need to decongest the patient. Diuretics are the main element, the main agent used to decongest. Is it really important to decongest? And the answer is yes. And what happens, somebody with chronic heart failure or acute heart failure, if they have an intake of 3,000 milligrams a day, that means you don't go and eat out, okay, more than once a week. Then actually the kidney through their angiotensin will release 2,000, but will keep 1,000. And for each 1,000 that's retained in the body, there will be of sodium, there will be 1 pound of water is retained. The rest is just time and math. And eventually you're gonna have congestion in every organ, first in the lungs, then in the gut, then in the legs. What do we try to do with the diuretic? Well, try to normalize this. Let's say I have this chronic neurohormone activation that is gonna make my kidney retain salt and water, sodium. And I just went out and I celebrate my birthday at whatever is the local favorite restaurant. I'm not gonna say the names. If you do that just once a day, you're gonna have that day about 5,000 milligrams sodium intake. But you know, your kidney is stubborn, and the angiotensin is not gonna let go more than 2,000 milligrams, okay? What happens? You retain 3,000. Then for 1,000, you retain 1 pound. Then suddenly you gain 3 pounds. Where are you gonna redistribute these 3 pounds? Well, it will be first in the lung. Now, if you're a big guy, 6'3", you're great. You can accommodate those 3 pounds because you got big lungs. But if you're a tiny little guy like me, if I get 3 pounds out in my lung, I'm gonna be in flash pulmonary edema. I'm gonna go to the emergency room. I will have acute on chronic. I will have alveolar signs. So, that depends of everybody's appetite, what they do. What do we do? If I go to ER with 3 pounds extra there, they're gonna give me furosemide or other diuretics, whether it's acute or chronic. And what we wanna do, we just try to normalize this. In other words, if I was positive 3,000 milligrams, ideally I wanna use a frequency and dose of diuretic that will just get rid of those 3,000, not the 3 pounds of water. Unfortunately, it's not perfect, science. I can never, although we put the patient on a chronic standard dose of diuretic, sometimes once a day, sometimes twice a day, sometimes higher or lower dose, it's not really perfect science because ideally I would like the patient to titrate depending how much sodium intake they had that day. Because if I overdo it and the patient is super compliant with low sodium and I give them a high dose of diuretic, it's gonna be negative sodium balance. They'll be dehydrated and they're gonna get side effects from my other agents that I use to treat heart failure. Or the opposite, if I don't use a diuretic strong enough for the amount of sodium the patient eats, then the other medicine won't work because the patient's congested. And it's about time it's gone. So you see why everybody loves to hate the diuretic using heart failure. We know it's gonna harm the kidney. The question is, how do we tailor it for a patient to get the maximum benefit and less risk? And those who are curious, I have a whole lecture that's in that portfolio. I posted a website. You guys can watch it, how to do it. Having said that, moving from stage A to B to C to D heart failure, and moving through our theories of how we actually were able to improve survival in patients with heart failure. Is really the neurohormone model is by far the best that we have right now. Basically, anything we do to neutralize either the adrenaline system with beta blockers or the angiotensin aldosterone system with ACE inhibitors, beta blockers, or, sorry, I'm gonna go straight to the medicines because I'm running out of time, all right? So either with beta blockers to inactivate the adrenaline, right? ACE inhibitors, angiotensin converting enzyme inhibitors, or angiotensin receptor blockers to inactivate the angiotensin part. Aldosterone receptor antagonists, remember, aldosterone causes fibrosis, so we need to prevent that or reverse that fibrosis in order to switch from irreversible cardiomyopathy to reversible one. And really, hydrolysis and nitrates is a combination of an afterload reduces active arterial vasodilator with nitrates, which is a venodilator that particularly in patients who are self-identified African Americans, on top of the other medicine, has shown to improve mortality and survival. More recently, though, there is a new medicine that is a combination of neprilysin inhibitor and angiotensin receptor blocker like valsartan, who has shown to actually be superior to ACE inhibitor. It works along the same concept. How is that? It's very simple. As I mentioned, progressive heart failure is progressive vasoconstriction, progressive neurohormone activation. Basically, your vasoconstrictor neurohormones are going to prevail, and they counterbalance the vasodilators one, which are supposed to protect the heart. That means your BMP level starts to go down because it's degraded. Bradykinin, everything is supposed to counterbalance. That's not going to be good. So how can we increase this vasodilated component? It's actually using, there is an enzyme that inactivates these guys that's increased in patients with heart failure. It's called neprilysin or neutral endopeptidase. We can actually block that with this medicine called sacubitril that's part of one component of this Entresto drug. So now suddenly I'm gonna inhibit the enzyme that neutralizes the BMP, which is very important. Sure, we always say we measure BMP as to see the neurohormone activation, but actually the BMP is supposed to count, is the native endogenous inactivated angiotensin 2. It's actually designed to counterbalance the effect of chronic angiotensin activation. So if we can actually, they thought very well, if we can actually make this BMP not just being up in the bloodstream, but also functional and not degraded, then maybe that will help to counterbalance the angiotensin. And separate, they fused this sacubitril with valsartan, which is an angiotensin receptor blocker towards straight at the peripheral level, into a new drug. They designed a trial called Paradigm HF, because the Paradigm is first time ever a new drug was created by fusing two different drugs. At the end of the day, it did show to be actually extremely superior to just an ACE inhibitor alone. You could say, well, why don't we use both an ACE inhibitor and a neprilysin inhibitor? Actually, that study was done with the omapatrolite because it blocks both. The catch was there's a little guy, the vasodilator guy, that we don't have too much. We don't want to have too much. It's called bradykinin. You need to, and bradykinin is inactivated two different ways, either neprilysin or the angiotensin converting enzyme. We learned that actually if we block both of these ACE and angiotensin converting enzyme and the neprilysin, actually you get tremendous elevation of bradykinin with angioedema as a side effect. So we convert basically somebody from heart failure into septic shock. We don't want that. So we learned the best ways to combine a receptor block of angiotensin with a sacubitril, which is the neprilysin. So I'm going to finish this pretty much. This is the slide that shows us these are the medicines that have been shown to improve mortality. Digoxin and diuretics have not shown to improve survival in heart failure. They do improve, symptoms. You can see why for the last 20 years I've chosen to do heart failure, because it makes my life so much easier. It's just 5 medicines that I need to know, and they're not growing more than that, all right? But really, you'll say, well, if diuretics have not been used to, they're not shown to improve survival, why are we using it? It's simple, because they are the one that makes the difference between decompensated and compensated. So then we can buy time on a chronic heart failure patient to use the other medicine to do the job. Also, congestion is the #1 cause of why patient comes in the hospital. And yes, we need to reduce the hospitalization if we can. So the last question, and with this, I'm done, and I appreciate everybody being patient here. Survival in patients with chronic systolic heart failure is improved by all medicines except, beta blockers, ACE inhibitors, the combination of the valsartan and the neprilysin inhibitor, digoxin, or aldosterone receptor antagonist. And the answer is really beta blockers, absolutely. Probably if I were to pick one that makes the biggest difference in survival is the beta blocker. One of these 3, they are shared. The long-acting metoprolol, beta-1 antagonist, carvedilol, and bisoprolol. So that's #1 that should be on the list of somebody with low ejection fraction. Again, ejection fraction less than 35%. And then probably next in terms of improving survival mortality would be the new combination of this neprilysin inhibitor, the sacubitril with valsartan. We call it commercially Entresto. I wish I don't have to use that name, but there is no other name we have right now. People will know it like that. The third will be an ACE inhibitor, and aldosterone receptor antagonist is extremely important through the cardiac fibrosis. But digoxin has not been shown to actually improve mortality, at least at this point. And this is a summary slide pretty much reviewing the main points of what we just said for you to read it and review it. And I'd like to thank you for being patient, particularly Dr. Kasimatis. I think I went over his time with a few minutes. So.
We have a couple minutes to take any questions. I'll see if any questions come up on the chat before we take a pause. Question from Malik Nelson. Can you repeat what you said about neprilysin inhibitors and septic shock?
What I meant to say is bradykinin is actually the main mediator into that mediates the vasodilation. Somebody who has what we call anaphylactic shock, like a very strong allergic reaction, let's say to bee or a drug. Really, bradykinin is the main mediator that causes the itch, causes the vasodilation, the hypotension, the angioedema when people choke and they are short breath from vasobronchoconstriction. In other words, normally body has a way of keeping that under check. You have to keep it under control. And there are two enzymes that neutralize our bradykinin at every given moment. One is the ACE, the angiotensin converting enzyme. The other one is the neprilysin. Okay? So my whole point was when we have learned that the hard way, we learned that we cannot use both an ACE inhibitor and a neprilysin inhibitor to treat these patients with congestive heart failure, with chronic systolic heart failure. Although theoretically blocking every pathway that involves angiotensin, increasing BNP would be wonderful for patients with heart failure. It turns out that we get side effects within a few days of too much bradykinin activation, angioedema, rash, allergy-like reaction, and also severe hypotension, which is also, bradykinin is involved not only in anaphylactic shock, but also in septic shock. And basically, we need to have one pathway of keeping the bradykinin inactivated. Either the ACE enzyme has to be available. That's why they use a valsartan, just blocking at the receptor below the Ang2, not at the ACE enzyme level. Or we need to, block the ACE enzyme, but leave the neprilysin being able. Okay, so.
Slide 32. Can you talk again about how increasing efferent arterial or resistance too much can decrease GFR?
Said 32?
32. How is it that when you increase efferent arterial or resistance too much, you decrease GFR?
Okay, you got it right. It's not because you increase efferent arterial resistance. It's because when angiotensin 2 goes up, you see what we're measuring here. Yes, you're right. The efferent arterial resistance keeps going up, but that's just a consequence of angiotensin keep going up. When angiotensin is activated at low levels, okay, it's only the efferent arterial that it's vasoconstricted. But when angiotensin 2 goes up and it keep vasoconstricting both the afferent arterioli and the efferent, then that's deleterious. In other words, here they measure the efferent arterial resistance, but what they need to add is another graph showing you now that concomitant with the efferent arterial resistance going up, you also have afferent arterial resistance going up. And that's actually what's causing the GFR to go down. Because once you also, so if you just increase in low dose angiotensin, you just vasoconstrict this, then indeed the pressure will be elevated in the glomerulus and you do a job. But if angiotensin 2 gets higher and higher, now it starts, you have receptors here also on afferent. Now you start to choke and cause also arterial vasoconstriction. And concomitant with this pressure still going up, now basically the kidney cuts its own blood supply to the glomerulus from the high resistance. And that's the mechanism. So it's not so much efferent arterial resistance keep going up, but actually adding an excessive afferent arterial vasoconstriction from higher levels of Ang2 that's causing this now GFR start to go down here. All right. And there's a beautiful chapter in Guyton. I don't know if you guys have time. I advise you. It's classic textbook. There's a reason why I have over 30 editions. It's amazing. That's how I learn it. It takes a little more time, but it's fabulous to understand this. So.
Good, you can hear me again. I think we will take a 8-minute, 9-minute break. We'll restart at 10:15 with a discussion of pericardial heart disease. So we'll go dark here for a moment, but the session will be the same number and we will resume at 10:15. Thanks, everybody.
Thank you.